for a best teacher in the college. I don't know if you do that. Okay. The speaker that you just had has 16 organ apples. Wow. For the College of Medicine. And I challenged him before I came here. If you can make them understand and learn how to read PFT in 1 hour, you will get another organ apple. And you know what? He just did. Congratulations to all of you that were following the lecture and were able to read that. Okay? Put that aside, let's go to the topic. I am the only thing holding you between UT and home. So I'll try to go to the point. That's the GPS of the lecture. Is that how you call it? You know, when you know where you're going, GPS. Okay. I'm going to talk to you about normal sleep, the history and physical things that you need to ask. Polysomnogram, that is the tool that we use to study sleep disorders. A few words of neurobiology and pathology. Is that fair? That's the GPS of the lecture. Okay. First of all, what is sleep? What I'm giving you right now is a behavioral definition. That's what all my psychology colleagues says. You know, it's a reversible state. Why is it reversible? Because it's not coma. Well, for some of you, it's not reversible. It's a reversible state of perceptual disengagement. When you're sleeping, you're not aware of what's happening around you. Associated with unresponsiveness to the environment, and usually, but not always, accompanied by recompensacy. There are people who can sleep sitting in a hall, and usually associated with physical quiescence. Those of you who are married may know that not always is associated. Right? I can see at least one or two people saying it's true. Now think about this. Forget that we are human beings. Mammals in the environment. When do you think they are more vulnerable? When they're awake, able to identify predators and run, or when they're sleeping? Okay. So does it make sense to have a noisy sleep in nature? That's the first thing that I want you to think and remember. Snoring maybe is not a healthy situation for mammals in planet Earth. You believe in biology. Okay. Next thing I want to show you is what is expected duration of sleep. When you're born, okay, you sleep in 16, 18 hours a day. And that pattern, persists for at least a year. Okay. By year 6, kids usually do not need to nap anymore. And their bowels are trained. That's when they go to school. Okay? And after that, we maintain a very similar sleep pattern, even until you go to my age. So the duration of the sleep is something that we need to respect. But let me go back to this. My granddaughter taught me this weekend here in Thanksgiving. He said, "Grandpa, the sun is down. We need to sleep. Okay? The moon is up. We need to sleep." But what happens after, what's his name, invented the light bulb? We became a 24-hour society. Who knows about the number one employer in Memphis? It's FedEx, right? And who knows about the hub? They call it like that, hub. It's a 24-hour enterprise. And when people are supposed to be sleeping, according to that, look at where Memphis is. There is a significant amount of people not respecting sleep. Yes, you're in doctoral program, so you need to study. So, yes. So I want you to understand that sleep is required for normal functioning. I want you to understand that we need to sleep certain amount of time. We need to understand that society imposes a restriction that fights to the need of sleep. Let me ask you a different question. Think about normal people. I mean, those are not the doctoral students. I'm talking about normal people. Okay. How many hours they sleep? Usually. Anybody? My questions are easier than Matthias. 8 hours. So is that 1/3 of the day? 24 hours, 8 hours. Is that a third? I was terrible in math, so. If we sleep 1/3 of our life, okay, it would have been a terrible waste of evolution if it's not dedicated to some kind of function. And my friend upstairs, he doesn't make mistakes. The fact that at the current level of knowledge, we do not understand the whole physiology of sleep doesn't mean that it's a worthless. Why should I sleep, right? You know, 1/3 of our life was designated to sleep. Part of the function has to do with regulation of hormonal function. Growth is only dependent on slow wave sleep. You know, growth hormone is secreted only at night during N3 sleep. So for those who have kids, eventually your teenagers are going to demand to impose the sleep schedules. The way I convince mine to go to sleep is I ask them, do you want to be short or tall? So because growth hormone is only secreted during sleep, and they all go right into sleep. Okay. The next component is sleep symptoms and history of physical exam. The most frequent reason why the patients see a doctor, a provider for sleep-related problems is for excessive daytime sleep. Adequate rest is required to have daytime, activity. And that happens at every level, including doctors, including truck drivers. You all know what is I-40? Picture driving next to an 18-wheeler that is sleep deprived. A blink of 2-3 seconds may be enough to create a tragedy in your family. Okay. In 3 seconds of driving at the speed of an 18-wheeler, it's like 2 or 3 football fields. Okay. Or imagine that's your OBGYN. Picture him doing a C-section in one of you when he's asleep. Okay. So we need to be concerned and respect the need of sleep so our daytime function is adequate. Our patients deserve that. In the same way as sleepiness is a problem, insomnia is a problem. It is said that at least one episode of insomnia will be suffered by half of humanity related to stressors like loss in the family, divorce, even the birth of a child can be a challenge. Insomnia is very closely related to seasons. When we have no sun exposure during the winter, there's seasonal depression, and seasonal depression is associated with insomnia. I told you about snoring and the need to be quiet during sleep. It's not natural to snore. Or you may have abnormal behaviors during sleep. Okay, have you heard the people who used to sleep in and do this sleepwalking thing? Picture that you're a sleepwalker in a college dorm in the third floor. And you are challenged because you have a test on Friday. Oh yeah, but there is a party of my friend. So they went partying, had a few drinks, they're studying until whatever time in the morning. They sleepwalk and boom, they die from the third floor. Just picture the consequences. Or nightmares. I work in the VA. We take care of those people who went for deployment in order to guarantee our freedom. And when they come back, they have significant mental consequences. They have PTSD, nightmare is a major problem. And abnormal movements during sleep. There is something called restless leg syndrome, in which patients feel the urgency to move when they go to sleep, or they have jerking movements during the night, or they may have seizures at night that needs to be identified and treated. So those are the reasons why they come to see us in the clinic. One difference between the HMP of a regular patient who has a disease of the daytime versus a disease of sleep is that we have double dimension for everything that we do. Meaning, you have to ask the history and physical to the patient and also to the bed owner. You have to ask what happens during the night and also during the day. You have to ask what happens during the weekdays and also during the weekend. Because it's the holistic, understanding of day and night, patient and bed partner, weekday and weekend that gives you an understanding of the behaviors during sleep. The other thing that I teach my fellows is high five and give me five. Have you heard that in high school, give me five? Yes. So think about at least 5 different components of the sleep history, which are how medications affect sleep. Your providers that are going to start giving diuretics, please don't give it during the night. Because there will be, interrupting the sleep to go to the bathroom, 2 or 3 times. So the best time to give diuretics is probably in the morning. Maybe not first time in the morning because when they wake up, they have dry state, but yes, definitely before lunch. And they have accumulated some of the fluids of the day. You need to ask about medical conditions. Have you heard the concept of paroxysmal nocturnia dyspnea? So people who, when they lie down flat, they may have shortness of breath. SHOB, as according to Dr. Matthias, it's not SOB, it's SHOB, in which they have as an indication of heart failure. Okay. Other medical conditions like prostate or diabetes, poorly control, they have polyuria, including at night. So medical conditions can influence the sleep problem. A third finger are neurological and psychiatric conditions. I mentioned already about PTSD. I mentioned already about depression. Sleep actually, the main function of the sleep is for brain protection. So if you have a stroke, that definitely will affect the sleep function. In my mind, everybody who had a previous stroke is required to have a sleep study to evaluate what are the consequences or residual problems after the stroke. But then again, let me give you the disclaimer. If I'm a carpenter and you give me a hammer, everything in the world will look like a nail. So, with that disclaimer, I say that anybody with a stroke may need a sleep study. And the most important thing, don't forget about circadian problems. Circadian problems means that are disorders related to light and night, day and night exposure. Examples of this: you live in Memphis and you go now to Cairo, Egypt. They have a different time zone, and you may be not adjusted to the new time zone. Or from here, you go to Beijing to see the wall, you know, and you go there and you're not adjusted. You're supposed to sleep during the night, but if you work in the hub, you're going to be disadjusted with your environment. Those are circadian rhythm disorders that need to be addressed, evaluated, and treated. So the five dimensions of the sleep, HMP, you know, medication, disease, neurology, and psychiatry, circadian rhythms, and the primary sleep disorders. The physical exam, something that is very important, is the uh, oral cavity. Okay? Think about the mouth as a cube. How many walls in the cube? Anybody? No?
Well,
Okay. No.
in a cube or a square?
A cube, a cube. So it's three-dimensional cube. Okay. So yes. So you have to describe when you see the mouth in a sleep patient all the walls. So the floor will be the tongue. The anterior will be how the teeth look. If they're grinding teeth. The posterior wall will be the uvula. Lateral wall, the cheeks and the tonsils and the palate. Okay. All of those are the descriptors required in the evaluation of a sleep patient, not only Malapati, that's what I see all the time, Malapati or whatever. Remember, Malapati is a score developed for anesthesia. With one proviso, when you do Malapati, you're doing it in wake individuals in a sitting position. When they sleep, they are supine and all the structures fall down. And the Malampati score actually is aggravated by posture. Okay. So that's the pathology of the sleep disorders. Remember the five fingers? The last finger was the primary sleep disorders. And I mentioned a few of them. Insomnia is the inability to start, maintain, sleep, early arousal, or interruptions are all insomnia. Could be short insomnia, long-term insomnia, which is very difficult to treat. Okay. Parasomnias is when you have abnormal movements during sleep. Sleepwalking is one, sleep talking is another one. And we usually classify them according to when during sleep they occur. Okay. If they occur in REM specifically, which is the period of the sleep that you are supposed to be paralyzed. Okay, those are called REM behavioral disorders or REM parasomnias. Very important to know the difference because that parasomnia in the future usually is associated with brain degeneration or disorders like Parkinson's or multiple system atrophy. Obesity has a relationship with sleep apnea. Super obese, I call it an emphasized obesity, I'm getting there, can give you obesity hypoventilation syndrome. One big difference, sleep apnea by itself is not associated with CO2 retention. Obesity hypoventilation syndrome by itself is associated with CO2 retention even during wake. And acid base, how do you compensate for high CO2? Anybody? With high bicarb, right? And you get that when you do your blood work. So if you see a super obese with a high bicarb, you need to think about obesity hypertension syndrome. Central sleep apnea is a very important to recognize because it's associated with heart failure or stroke, or nowadays with the epidemic that we have of opiates. Okay? All the opiates and pain medicine can give you central apneas that are treated completely different. Those are not going to be controlled with CPAP. I mentioned to you the circadian rhythm disorders and the diseases of excessive daytime sleeping. Who has ever heard the term narcolepsy? So you all do. Now let me picture, who have kids in this room? Very few. Okay. So let me picture this. Just picture that your kid goes to school. Is that something expected in the life of a kid? Now, picture that that kid in school falls asleep all the time in class. How's his education and learning going to happen? Not only that, picture that he goes to play in the playground with his peers and friends, and somebody tells him a joke, and he drops with cataplexy. What kind of quality of life you will have? And if you fall asleep when he's becoming your age group, how safe he will be driving from here to whatever neighborhood he lives in, close by Mississippi or Colorado. So narcolepsy is a disease that disturbs the quality of life of an individual and lasts a lifetime. Okay, and it's incurable. We can control symptoms, but it's not curable. Leg disorders. Imagine yourself that you're trying to fall asleep because the lecture is boring, and you start feeling crawling sensations in your leg that doesn't let you initiate sleep, restless leg. And finally, other medical conditions that may affect sleep. So the menu of a sleep disorder is extensive and is usually diagnosed with an adequate history. In the bottom is your age group. On the y-axis is the percentage of people in that age group that have a sleep disorder. You're probably in the 20s, 30s, right? So that means that 20%, 1 out of 5 in this room may have some kind of sleep disorder. Wait until you go to 50 years old. That's the age of your parents. Half of the population in that age group is going to have a sleep disorder. Okay, definitely, if you go to the 70s, at least 2/3, 3/4 of the population will have a sleep disorder. It's for you, when you evaluate patients with appropriate age, to search, look, and identify what could be this sleep disorder so you can treat it appropriately. If 1/3 of your life is spent asleep, nurse practitioner school give you a 1/3 education on a sleep disorder, or probably it's going to be one lecture for the 7 years program of nurse practitioner. Well, 7 years for some people, you know. So just think about it, because the opportunity that you're going to have to capture knowledge about 1/3 of the life of your patients is this hour. Just think about that. So what are the consequences of bad sleep? You may have a car accident. You will hear, I can guarantee you, before you finish your doctoral degree, by the way, I wish you the best of success. One of you will have a car accident, either because you fall asleep or somebody in the road falls asleep. Okay, let's think about that. Sleepiness. Okay, you may be in a very interesting lecture like this one, but if you have a sleep disorder, you will find sleepiness and miss half of the information. The cognitive harm. This is very important. In order to be able to learn, you need to be rested. Okay? One of the functions of sleep is thought to be the filtering of information. So during sleep, your brain decides this information is good, I'm going to keep this information is bad, I'm going to delete or erase right C or cerebrum. So the functions of sleep has to do with cognitive function. bed partner. Okay, I have heard stories of wives saying, I cannot sleep in the same room that that guy. I'm going to go to the next room, which is not a nice scenario for the consolidation of a family. Cardiovascular disease, hypertension, heart failure, pulmonary hypertension, very important arrhythmias, atrial fibrillations. Have you heard of the story of, oh, my uncle fall asleep, never woke up. He falls asleep in the middle of the night. Okay. Arrhythmias and sudden death events happen in sleep apnea patients during the night. The rest of the population, usually in the early hours of the day. That's going to be you if you don't rest. What do we use to evaluate sleep disorders? Usually what's called a polysomnogram. A polysomnogram is a study that we put wires in your brain to do an EEG. We put a sensor in your mouth and nose so we measure the flow, and sensors in your ribcage and belly to see the effort of what you're doing. Okay, that's enough wires. Yeah. Also, we put wires to measure the muscle activity and the chin activity and your eye muscles. So we can stage REM, rapid eye movement sleep, versus non-REM sleep, and the EEG will tell you if you're awake or asleep. So the polysomnogram will give us the differentiation between you're awake or you're asleep and the state. An important thing that gives you is what we call the sleep architecture. So what is the sleep architecture? Sleep is not uniform. It's not because you are dreaming over there, you're in sleep that is uniform. Sleep is a very active process, and every 90 minutes cycles, you go from stage 1, stage 2, stage 3 sleep, and then you go to REM. Then you go back again to stage 1, 2, 3, and then back to REM. And you go through 4 or 5 cycles of this architecture. And you need to identify that the architecture is appropriate, because each level of sleep has different functions. Okay? That's a typical hypnogram, we call it, of the whole night of sleep. Okay? In which you fall asleep in less than 20 minutes, you go to stage 1, 2, and go to deeper level of sleep, then you have a short period of REM. The longest REM period is at the end of the night. The shorter REM period is at the beginning of the night. And that's a normal architecture that you can differentiate with the polysomnogram. Everybody, can you make a fist? Don't hit me. But that's the size of your thalamus. Anybody, what is the function of the thalamus? Thalamus doesn't move anything. You did neuroanatomy, right? You saw the thalamus. So for your brain to have something that is the size of your fist must be important. This is a big chunk of tissue in your brain. So what's the function of the thalamus? Anybody? Yes, I agree with you. Yes, I agree with you. So let me tell you, the thalamus is the break point. When you fall asleep, all the sensations from your body, before they go to the cortex, stop in the thalamus. The state of perception, disengagement with the environment is provided by your thalamus. You need to have a normal functioning thalamus for you to be able to have a good sleep. And if you've seen CT scans of a stroke patients, the majority of them will have involvement of certain portions of the thalamus. That's why, in my opinion, if you give me a hammer, everything will look like a nail on the wall, meaning that I will do polysomnogram in everybody with a stroke. Many nuclei control the function of sleep, and don't need to worry you about that. Know that melatonin is probably the switch that makes you fall asleep. Know that there exists pulse secretion of hormones. I told you already about the growth hormone. Only happens in N3 sleep. Prolactin also has a pulse secretion. Okay. When mama wakes up, what is the first thing it does to the baby? Pizza. After prolactin. And something interesting, all beings in planet Earth sleep. Isn't that interesting? So there must be a function that says in biology you need to sleep to do something. The duration is different. Oh, you heard the concept about the cat nap, right? That's the cat. You know why it's called cat nap? Because they fall asleep very fast, and in 20 minutes they fall into REM. So the short naps of 20 minutes are called cat nap. This being is one of the ones that sleep the less amount of time. Why do you think that is? It's dangerous. You know, the way the lions and tigers kill these beings is they jump into the neck and bring the head down when they're standing. You know why? Because the heart of the giraffe has to pump all the way up to the 7th floor. So they have a huge heart, huge strength, and huge pressures in the circulation. So if you bring the head down, what will happen? The blood pressure will make intracerebral hemorrhages, and they die. Because they jump to the neck bone to get down. Be careful. So if you put your neck down, be careful. Because I saw somebody doing something like this. That's why the giraffe sleeps 2 hours. Some people sleep like a bat, right? You know? So the duration is different. Who knows why? But everybody needs to sleep. This is interesting. I love this. You know what cetaceans are? There's a picture of one. The whales, dolphins. They can sleep with half of the brain. Isn't that interesting? So they're swimming with half of the brain sleeping. And when that side is rested, you know what they do? They flip to the other side and then they keep swimming. Can you imagine that in humans? We don't do that. But just imagine how much party I can have during my school years if I can sleep only with one half. So biology is interesting. Some people are doing it in spite of that, but biology is interesting in the sense that sleep physiology is different among species, but we all sleep. This is a doctoral student. That's one of your patients. And those who have been pregnant, they know sleepiness is associated with first trimester. Oh, these are twins. I love this one. And insomnia is a real sleep problem. She's thinking, I have a test tomorrow. They're going to ask me about sleep. All right, so I mentioned to you about sleep, the physical exam, and the history of sleep, the staging of sleep, a few peculiarities of mammalian sleep. Let's go to the pathologies. Okay. Sleep apnea is probably the most frequent sleep disorder of the adult, especially males. But sleepwalking are non-REM parasomnias that also exist. It can be normal in kids up to age 11. Parasomnia that is frequent in kids is enuresis, where, bedwetting can be related to that. The sensations in your legs, restless leg syndrome, is another important thing that you need to remember. 40% of the population snores. Believe me, snoring is not normal. The prevalence of snoring increases with age and increases with body weight. But not because you snore, you have sleep apnea. Only 10% of the snorers will have sleep apnea, but you don't know who. So that's why you need to be tested. If you snore and you are sleepy, that is a consequence of poor sleep quality, you definitely need to be tested. If you snore, you're sleeping and you have a comorbidity, hypertension, heart attack, liver, hepatic liver, how you call that, fatty liver, okay, or NASH, you need to be tested because you have comorbidities that are associated with sleep apnea. Why do you have sleep apnea? Because when you're dependent, recumberent during sleep, the weight of the tongue falls into the back and occlude the airway. And that's what's called sleep apnea. The snoring is produced by the flapping motion of these tissues around it. But the site of obstruction, question for your exam, in the sleep apnea is above the epiglottis, behind the tongue. Okay. Do I bring PTSD images to the married ladies in the room? Okay, so the family relationships can be altered by sleep problems not adequately addressed. And don't be like my patient that say, I love you during the daytime. Prevalence of sleep apnea 4% in the overall population. But if you take the population between 30 to 60, it's 3 or 4 times that. Now, the population between 30 to 60, is that the population that parents and take care of the kids? Is that the population that sees that all parents are doing okay? The working populations of the country has a prevalence of sleep apnea close to 15, 20%. Okay? And that's for you when you're doing your practice to think about it, ask the appropriate questions, and do the appropriate testing so you can help them. The productivity of a treated sleep apnea patient increases. That's a polysomnogram with no flow of air, so it's flat. And it's no flow of air because the obstruction. And the O2 saturation, what is the normal O2 saturation? 99, 98. In this case, went down to 80. And I have seen 70s. I have seen 60s during sleep, not a healthy process. And the problem is this. This is a society of plentiness, and the number one demographic change in the country, according to NHANES, is weight-related problems. This one just found a way to not detect. I love this one. That's what I do. So, and the best treatment option is probably CPAP. I brought this slide because I think it's applicable to every kind of therapeutic interventions that you will do when you practice. I can see one of you will probably be taking care of me someday, so I want you to think about this. When you decide a therapeutic intervention, you need to know if the intervention has proven efficacy, if it's likely, or unlikely, or no therapeutic efficacy. Same thing with safety and the cost effectiveness. So every therapeutic intervention, think about the efficacy, safety, and cost effectiveness. CPAP is a proven in therapeutic intervention that is safe and it's very cost effective. One machine is $500, lasts for 10 years. That is $50 a year. 50 weeks is $1 a week. What disease costs $1 a week in medication or the treatment? And you can follow with the downloads of the CPAP, the computer chips that the machine has will tell you sleep patterns. Like this one is a very interrupted sleep pattern, but they use the machine, except for these days that they use it that much. The final words about circadian rhythms. Remember when it's daytime here, the middle of Europe, Africa, they should be sleeping. Circadian rhythm is probably one of the first things studied in sleep medicine. This is in the 1700s. A French physician decided to evaluate the response of plants to light. And found that even if you put it in a box, okay, the response maintains. So the circadian rhythms are maintained. Who knows about the moonflower? It's intrinsic from Tennessee, by the way. So if you go around, you may see something like that. What's that? Really? Wow. Isn't that beautiful sound? So during the daytime, they're like this. But as go by during the night, they open. So it is a circadian response to the environment. Look at that. You like that? It's a Tennessee flower, the moonflower. And we call it moonflower because it's open when the moon is up. Okay. During the middle of the day, at night. More about circadian rhythms and how do you measure sleep? Usually by questionnaires, not the best way. I like to do it with MSLTs, too expensive, not for everybody. You need to do this when you think in narcolepsy. Narcolepsy, 100% of the patients will have sleepiness. Cataplexy, those episodes that they, sort of pain, 3/4 of them. But they may have hallucinations at the beginning or at the end of the sleep, or episodes of sleep paralysis. If you have sleep paralysis alone, you don't have narcolepsy. I can bet that at least someone in this room has felt the sensation of waking up and being unable to move. And you have what is called sleep paralysis. So a dissociative state during sleep, emotion, and last few slides. If you drink, your psychovigilance response is decreased. The guy in the right side has 0 drinks, but the psychovigilance response is as bad as if he wouldn't be drunk. So not sleeping is associated with poor neurovigilance, similar to being drunk. Okay. So be aware of that. How do you measure that? With driving simulation tests. This is a patient, and what you measure is the spread. How do you fluctuate? Has been sleeping for 7 hours. This is how it switches. This is one that has sleep restriction. And that's after coffee. So there are medications that can stimulate wakefulness, help you with concentration, but do not overcome completely the lack of sleep. So my objectives have been to present you the medicine of 1/3 of the life of your patient. My objectives have to present to you the different symptoms of physical exam science that I know you will evaluate from now until the end of your days, to identify patients that may be benefit with the approach of sleep medicine. And something that your teachers know, the vision that I have about sleep medicine is that eventually in the transition of the next 10, 15 years, is something that will be practiced by primary care providers, nurse practitioners, PAs in the community. So this is probably one of the new specialties that is going to be in your field for you to embrace, learn, and develop in the future. It is so important that we have early conversations with your faculty to open a rotation that is dedicated to sleep in the hospital. So those of you interested, if you know Dr. Reed, please talk to her. She may guide you on how to do a rotation about sleep. With that said, I just want to congratulate you one more time for tolerating me and surviving for 3 hours of lectures. And isn't that a beautiful picture of Memphis? I love it. And I'm all yours if you have any questions or comments, anything that you think I may be helpful. Don't hesitate.
I have a question.
Yes.
So like sometimes I'll hear patients say, oh, I don't want to go do the sleep study because I can't sleep if somebody's watching me. And the answer will be, well, we'll just do the home oxygen monitoring to see. Is that acceptable?
The answer is yes and no. Isn't that the answer of a man? Yes. So if the only thing you want to do is document apneas, it is acceptable. But that's the only thing you do. But doesn't give you information of brain function or what happens with the rest of the sleep pathology. Okay.
Could it be enough to diagnose it in the CPAP?
Yes, if your only concern is sleep apnea. But if you go to see your physician, would you take a physician and pay a fee if they only look at the right arm and don't evaluate anything else? So that's that. Yes.
You may not know about this, but I had a few patients that came in and they would show like their phone app or their watch
Yes.
app and say, look, I can't sleep
Yes.
because, it's telling me I'm not sleeping well. Do you have any idea what the technology is they're using and if it's actually accurate or not?
One more time, yes and no. So is it useful? The answer is yes. The way I use the apps in the phone is to monitor and train the information. But once they come with something that shows abnormality, I need to confirm it with real stuff. So that's the way I use it. So yes and no. All right. Thank you one more time. If somebody has more concerns, I'll stay here for a few more.